Good evening, everyone. Today we'll be talking about the fractures of the individual bones of the hand. Sir, can I have your permission to extend it for about 15 minutes?
No, your time till whatever, till midnight, no problem.
As long as they can bear it.
Yeah.
Okay.
Because we have no program today.
Yeah, sure, sir. Sure. Thank you. So today the talk will be on the, as I said, the fractures management of the individual bones of the hand. So as I said, the management of the fractures of the finger bones. Today, they're going to deal with only the metacarpals, the proximal phalanx, the middle phalanx, and the distal phalanx of the fingers alone. I am not going into the thumb bones today, as this topic itself is quite vast, and it is imperative that we understand the principles done. It is not just I'm going to show you pictures of a fixation and all that. How is it decided what is to be done, and the basic principle of how it is to be applied. The most important thing, you know, in hand surgery or in plastic surgery is the planning, and that is what we're going to talk about today mainly. And of course, the quiz for the day. Now, before we start off, we'll have just a quick recap of what we saw last week in the basics of fracture management. We saw that the available modes of treatment are external immobilization, closed reduction and external fixation, closed reduction and internal fixation, then coaptive fixation, stable fixation, rigid fixation. Coaptive fixation being the K-wires, nails and all that, and stable fixation being the tension band wiring, and rigid fixation being the compression plate and the lag screws. So with this, armed with this knowledge, and we already know that among these, the first four, that is external immobilization, closed reduction, external fixation or internal fixation, and coaptive fixation, give only secondary healing. Please remember this as we see the management of the different fractures. And stable fixation and rigid fixation give you primary healing. Now, first we will deal with the metacarpal fractures, as that is quite a load. It's quite a lot to deal with. Now, the metacarpal fractures account for 40% of hand injuries, and metacarpal neck is the most common site of fracture, and the metacarpal is the most commonly injured metacarpal. And this is the fracture of the neck of the fifth metacarpal is typically known as the boxer's fracture. Now, the metacarpal consists of the head, neck, shaft and base. So when we're going to deal with the management of the fractures of the bones, we will deal with each of these segments. Before we go into the management, we need to understand a little bit of the anatomy of the metacarpal bone, which is quite important as far as fixation is concerned. Now, we need to remember, one is the shape of the bone. If you remember, the shape is slightly concave to the volar aspect. That means the surface that is on the volar side is the compression side, and the surface on the dorsal aspect is going to be the tension side. You remember we saw last week about the tension and compression side. Secondly, the insertion. You got important muscles being inserted. Extensor carpi radialis longus and brevis inserted into the base of the second metacarpal and third metacarpal respectively. Extensor carpi ulnaris inserts on the base of the fifth metacarpal, and operans digitae minima inserting on the radial surface, that is on the medial surface of the metacarpal 5. Now these we remember. Notice that there is no insertion of any muscle on the fourth metacarpal. That will also come in important as we deal with the management of the different fractures. Clinical examination, yes, it must be done. It is not that they're going to treat the X-ray. Clinical examination is very important. Open wounds or associated injuries must be looked for. Can be associated with extensor tendon injuries. Maybe, usually blunt injuries are not associated with the tendon injuries. The open injuries are, it may be associated with skin degloving or obvious loss, and edema or compartment syndrome may result. For instance, you may get a patient like this. You can see the amount of edema here, and the Palmar edema is not very obvious. It's more the dorsal edema because the subcutaneous tissue is quite lax on the dorsal side. So this has been fixed with the fracture of the 3 metacarpals. So the decompression is very important. Even if it is not an indication for open fixation, it is ideal to open it, fix it, because it decompresses and opening it is just not enough. You have to decompress the compartments. You can develop a compartment syndrome if it is left to heal on its own. So this is the result in that patient. You can see the good healing of the good alignment and the good function that is. This is very important. So this is the first thing, clinical signs. If you find a lot of edema, think more about an operative management, opening the hand rather than a conservative management. Then next we need to look for deformity. Now what are the deformities you're going to look for? You're going to look for shortening or apparent shortening of the finger. Apparent shortening, usually up to 1 centimeter of shortening can be adjusted and functional, there is no functional deficit. But there is one problem. When there is a shortening of the metacarpal for about 1 centimeter, even though the function is good, there will be a loss of the knuckle prominence, and that is cosmetically disfiguring for a lot of patients. So that we should keep in mind. Second is angulation, rotation, and swelling. We'll see more about this as we go along. How much of angulation can be accepted, and beyond what angulation you should plan for a open reduction and internal fixation. See, now this is the commonest deformity that we come across. There is usually an angulation like this, which is causing a flexion deformity. Now this is typically because of the insertion of the intrinsic muscles. They pull it into flexion. This must be remembered, and we must understand that we must negate this force if you are to get a good fixation. And clinical examination, as I said, you need to look for an extensor deficit. Now, sometimes there will be no injury to the extensor tendon, but still you will have something like this, some deformity like this. Sometimes if all the metacarpals are fractured, you will have a deformity like this. This is because of the biomechanical disturbance that is occurring there. When there is a flexion deformity at the metacarpal shaft, there is an apparent lengthening of the extensor tendon. So it leads to something like a pseudo claw deformity. So when it occurs like this, that means there is a deformity at the metacarpal, and this must also be addressed. What are the radiographs, X-rays we're going to ask for? Usually a posterior-anterior view of the hand, a lateral view, and an oblique view. 3 views are actually required. Now here a true lateral view will help us to decide what is the angulation, because that we'll be seeing how much of angulation can be accepted, as I said. Now for oblique views, there are 2 different views that can be taken. For the 4th and 5th carpometacarpal joint fracture or dislocation, we can take an external rotation or internal rotation in this position, or external rotation depending on the metacarpals that you want to visualize. There is an optional view that is when you want to see the metacarpal head fractures more clearly. In a usual PA view or lateral view, there is an overlap and of the shadows, so you cannot make it out clearly. The Brewerton view is the best view to see metacarpal head fractures. This is how it is taken. It is kept on the plate like this, and the film is focused like that, and you get a good visualization of the metacarpal heads. So now we'll go, we have clinically examined, we have taken the X-ray, and we have seen the fracture of the metacarpal bones. Now we are going to decide on the management. Obviously there are 2 types of management: non-operative management and operative management. Non-operative management, believe me, is one of the most attractive options. Please remember last week when we talked about the basics of fracture management, I told you the complications of non-operative management of fractures is only deformity. The complications of misguided operative management of fractures is not only deformity, it is also stiffness. So keeping this in mind, we will go into the management. If we are going to decide on non-operative, yes. If you're going to decide on operative, what is the technique we're going to follow? Is it going to be a plate and screw? Is it going to be a lag screw? Is it going to be K-wires? what? We'll see that. Now, the indications for open reduction. Before we go into non-operative management, we should first decide which are the patients who need an operative intervention. So you're converting, if it is an open fracture, if it is an open wound, obviously it goes in for open fixation. If it is a simple wound, you have to decide on which are the patients who need an open reduction internal fixation. So there, a displaced fracture, that is a fracture which will not be stable on reduction. As you know, the two basic steps of fracture management are reducing the fracture and immobilizing the fracture in that position. So if it is reducible, it is either irreducible or reducible but doesn't stay in that position, you have to go for an open reduction. If it is an unstable fracture pattern, for instance a transverse fracture, a straight transverse fracture will be very unstable on reduction, or a long spiral or an oblique fracture, or multiple metacarpal fractures. When there are multiple metacarpal fractures, it is not possible to mold all the fractures and do a conservative management. You will not get a good reduction and a good alignment. So we need to do an open reduction. Next is angulation greater than acceptable, that we'll see. And deformity and open injuries, as I said, and polytrauma patient, because there may be other more important injuries. So here we need to do an open reduction internal fixation. So basically multiple metacarpal fractures, sometimes even single metacarpal fractures are involved. There we decide more on open reduction if it is an marginal metacarpal. For instance, the second metacarpal bone, if it is a simple fracture, we decide more for a fixation, open reduction, or a fifth metacarpal. So the marginal metacarpal, the second metacarpal or the fifth metacarpal, we will decide more towards open reduction rather than closed reduction. Before we go into the management, there are certain things that are very common for management of metacarpal fractures. The position of the metacarpophalangeal joint is the most crucial to the recovery of function. I have seen a lot of people who do a fantastic fixation but do not worry about the POP, give it off to the theatre worker. Please, the position of the metacarpophalangeal joint will decide to make or break your fracture fixation and the results. So it must be kept in 90 degrees. There is absolutely no compromise on this. And the approach to the fractures is through the dorsum of the hand. We must remember that underneath the skin we have very little fat, and directly you have the extensor tendons and then the bone. So they are almost subcutaneous. Then support is needed for these metacarpal fractures up to 1.5 months. Even though we remove the K-wires, if you're going to put in K-wires, even though we remove it 3 weeks to 4 weeks, please remember these metacarpal bones are still evolving and you need to support them for 1.5 months. Otherwise they buckle. I told you there are compression forces and tension forces. The compression forces are much stronger. The flexor tendons are much stronger. They will buckle the metacarpal. And the role of tension band wiring will be stressed, and the aim is to maintain the length of the metacarpals. I told you, you need to have cosmetic and functional recovery. So when we come to non-operative management, indications are: one, when you're not deciding on an operative management, you go in for a non-operative management, which is immobilization. And the fracture must be a stable fracture, typically of the fourth metacarpal, because there is no forces acting on it. But even in the fourth metacarpal, if it is a transverse fracture or unstable fracture, it's better to go in for fixation, or if there is an angulation. And no rotational deformity. There are different types of deformity. You can have angulation, you can have shortening, but rotational deformity and angulation and shortening can be accepted up to a certain degree. But rotation deformity, even a single degree of rotation deformity cannot be accepted. It must go in for fixation. Now acceptable shaft angulation for the index and mid fingers is 10 to 20 degrees. For the ring finger is 30 degrees, and for the little finger is 40 degrees. This is the acceptable shaft angulation. If the angulation is more than that, it needs to go in for a fixation. Similarly, acceptable neck fracture angulation is 10 to 15 degrees for the index and mid fingers. Ring and little fingers, it is much more. how is it that the ring and little fingers are able to tolerate so much of angulation, whereas the index and mid fingers are not able to tolerate even a little bit of angulation? You need to fix it. The reason is the ring and little finger metacarpal joints, there is a movement already there. So this movement of about 30 degrees at the CMC joint of the index and mid finger of the ring and little fingers will compensate for the angulation that is going to occur. Whereas for the index and mid fingers, you know, it forms the fixed post of the hand, the second and third metacarpals. The metacarpal joint, there is no mobility at all. So here it will not tolerate even that much, even the 10 to 20 degrees of angulation will not be tolerated. So this must be kept in mind when we are planning the management. Now, having decided to immobilize, having decided to do a non-operative management of the metacarpal fracture, we need to remember that our POP that you're going to apply must be very strictly done. You can even give a block if the patient is very apprehensive. There is nothing wrong in giving a block because it is so important to mold that fracture and give a correct POP. Gauze between fingers, a very thin padding, soft padding can be done or a thin padding can be done. Reduce the fracture with the JAWS maneuver. I'll tell you about this JAWS maneuver. Then the POP is applied with the wrist in 20 degrees of extension, MCP joint in 90 degrees of flexion, and the interphalangeal joints in complete extension. Some methods leave the interphalangeal joints free for movement, but the movement here causes some amount of strain on the fracture line when these extensors and flexors are moving. So it is better to immobilize completely the wrist, MCP joints and IP joints. And why we keep the wrist in extension is only when it is kept in extension and the MCP joint stays, there is a counter force and a force which balances the stability that is being given to the metacarpal. So this is the JAWS maneuver. It is flexed at the metacarpal phalangeal joint by giving force on the proximal phalangeal region, and then we flex the interphalangeal joints. When we do this, what happens is the extensor tendon completely brings it into reduction. It reduces the fracture and maintains it in that position. So if you find it difficult to reduce a fracture, always use this maneuver, which is called the JAWS maneuver. Now, we have seen the principles of the conservative management or the immobilization non-operative management of the metacarpal fracture. Now we'll see the different parts of the metacarpal head fractures. Now, conservative management of the metacarpal head fractures is not very ideal. Operative management consists of external fixation, especially in severely comminuted fractures. If you are going to manage these head fractures conservatively, there is a problem. Even a millimeter of projection, that is misalignment of the articular surface, will lead to stiffness in the metacarpal phalangeal joint. This will definitely lead to restriction of the function of the entire finger because the metacarpal phalangeal joint has a large range of motion. If this becomes stiff, the span of the finger movement is reduced. So, operative management with the external fixation, if it is comminuted fractures, or internal fixation can be done. When there is no degree of articular displacement acceptable, and majority requires surgical fixation because you cannot have any amount of displacement. In that situation, we need to fix each and every fragment that we see unless it is very comminuted. If it is very comminuted, you go for an external fixator. External fixator must be applied with the metacarpal phalangeal joint in flexion. If it is less comminuted, we try to go in for a fixation like this. We open it on the dorsal aspect, split the extensor apparatus, or release and repair the sagittal band, because at this point you have got the extensor sagittal band. Then we fix it in such a way that the hardware should not protrude from the joint surface, and we fix with multiple small screws in the collateral recess head of the or the K wires. Now, ideal fixation should allow for early motion. The whole point about metacarpal head fractures is movement, and internal fixation should allow that movement. So, You can have either subcapital fractures or intra-articular fractures. In intra-articular fractures, definitely it needs screw fixation. Whereas subcapital fractures, even K-wires can be used. Now these are intra-articular fractures. You can see the screw fixation being done. Now we'll go to the metacarpal neck fractures. Now the boxer's fracture, I told you, is one of the commonest fractures that can occur. The non-operative, is there a role for non-operative management? Yes, there is a role for non-operative management of metacarpal neck fractures, especially the fifth metacarpal fracture, because that is the commonest. Reduction and POP application or casting, provided that there is an acceptable degrees of apex dorsal angulation. It must be acceptable. We already know that the little finger can tolerate up to 50 degrees. But it must be less than that, the angulation, and we must reduce. This is very important. We must reduce this using the jaws maneuver and immobilize the metacarpopharyngeal joints in 90 degrees of flexion. It is so important here. Once you reduce the fracture, if you do not concentrate on the POP, what happens is it again starts buckling and you do not get a good result. And the POP should be retained for 4 weeks. I told you, even though you retain the POP for 4 weeks and remove it at 4 weeks, we must continue to support the fracture even after that for another extra 2 weeks. Now, the operative management of these fractures, indications are unacceptable angulation. We have seen that. Open fractures, we need to fix it. And any malrotation, I told you, no degree of malrotation will be accepted, and intra-articular fractures. These are the 4 indications for neck fractures of metacarpal for open reduction. Now the technique again is jaws maneuver. Under anesthesia, the fracture is reduced, and there are 2 types of fixation. The fixation, once you have decided for an operative management of the metacarpal neck fracture, there are 2 types of fixation. One is the close reduction percutaneous pinning. This can be done either antegrade or retrograde. That is, antegrade is, now this is an example of a percutaneous pinning done for metacarpal neck fracture. The antegrade goes through the metacarpal base and the retrograde comes from the metacarpal head. There is another method of pinning known as the transverse pinning. That is, when you have a fracture and it is very unstable and it is comminuted, you cannot fix it, you can always pass a transverse wire between that injured metacarpal and the next metacarpal that is stable, that is not fractured. So that maintains the length. Remember, I told you maintaining the length of the metacarpal is one of the aims in the management of metacarpal fractures. The second, so the first was close reduction and percutaneous pinning. The second type of management is open reduction, internal fixation. This can be done with what is known as tension band wiring. This is very important. We understand the principle of tension band wiring. Now, when you have a fracture like this, now this I'm showing the shaft, but it will be the same for the neck also. When you have a fracture like this, I told you it always goes in for a flexion, because this is the tension side and this is the compression side, right? There is more force on the compression side, so that is why it's going in for flexion. So what we need to do is we need to lift it up like that. We need to lift up the neck and the head of the metacarpal and bring it and fix it like that. So this can be done with 2 techniques. You can do an interosseous wiring with either a square knot or a figure of 8 knot. Now imagine if this being done on the neck. Can you see this? Something like a figure of 8. Now this holds it up, and this can be done, and this is the result. Or you can do the same thing with plate and screws. But remember, the principle of tension band wiring is that the forces on the tension side are converted into compression forces. So there is compression on the tension side. So naturally the healing will be much better, and it is more of a stable fixation. Remember, the tension band wiring is one of the methods of stable fixation. So this must be remembered whenever you have a fracture of the neck of the metacarpal. Now look at this patient. Forget about this patient had fracture of the proximal phalanx also. Just forget about that. Just look at this neck fracture of the 5th metacarpal. Look at this angulation. It's almost 80 degrees. So this has been fixed with square knot. Can you see the square SS wire? We use usually 22 to 24 gauge stainless steel wires. We pass in a K wire. We don't pass it completely. We just keep a K wire there. Pass 2 transverse drill holes on the head and the proximal to the fracture. Thread a stainless steel wire and then tie the knot. Usually we try to get the knot on the non-contact side so that it doesn't irritate the skin or there when the contact is being done. So these are, now we have seen about the metacarpal neck fractures where we saw the conservative management, and then we have seen the operative management. Now we come to the metacarpal shaft fractures, which are quite interesting and which are quite varied in the management. Now, as far as the shaft fractures are concerned, they can be transverse, they can be oblique, or they can be multi-fragmentary or comminuted, in other words. Now, even for shaft fractures, there is a role for non-operative management. The non-operative management, as we know, consists of immobilization. When do we do this? Immobilization for shaft of the metacarpal fractures. When there is a non-displaced metacarpal neck fractures or non-displaced metacarpal shaft fractures, acceptable angulation, no malrotation, and there is a minimal shortening, but this will cause aesthetic problem. So if the shortening is quite obvious and there is a loss of the knuckle prominence on clinical examination, we need to decide for a fixation. And we need to immobilize the metacarpophalangeal joints in 70 to 90 degrees of flexion. I keep repeating this point of dealing with the metacarpophalangeal joint, and the cast, the POP or the cast must be applied for 4 weeks. Now we come to the operative management. This is very common. Operative management indications are open. We have already seen the indications: open fractures, unacceptable angulation, any malrotation, multiple fractures, and also marginal metacarpals. That is the second metacarpal or the fifth metacarpal. Now we need to decide on what we are going to do. You can do either an open reduction or a closed reduction and percutaneous pinning. Now we'll see there are 4 methods of operative management of metacarpal shaft fractures. The first is closed reduction percutaneous pinning. The second is open reduction with lag screw. The third is open reduction with dorsal plating, and the fourth is open reduction with K wires and stainless steel wires. Now these are the 4 main methods of open reduction of metacarpal fractures. We will deal with each of them. Now we will see the percutaneous pinning. Now this, as I told you, it can come in the retrograde fashion or in the antigrade fashion to put in wires. Now this is the closed reduction percutaneous pinning. As far as open reduction with lag screw, this is done when there are long spiral fractures. When do you say it is a long spiral fracture? When the length of the fracture is more than 2 times the cortex diameter. That is the width of the bone. Supposing the width of the bone is about 1 centimeter, if it is more than 2, if the length of the fracture is more than 2 centimeters, we call it a long spiral fracture. There you can use lag screws alone for the management. There is no need for using plates. So here, how is this lag screw fixation done? Now I told you this is more than 2 times the diameter of the bone. It is called a long spiral and it needs a lag screw fixation. Now first is, there are 6 important steps in fixation with a lag screw. The first is drilling a hole across both fragments, and it must be kept at right angles to the fracture line. Second, countersinking. Now countersinking is a procedure by which the screw does not stay outside, but it goes and flush with the surface. So it is not just a drill hole you're making. The opening of the drill hole on the cortex, you're making it wider so that the screw can sit flush with the surface. Third is determine the length of the screw. Fourth is drill a glide hole with a larger drill bit. And fifth is tighten the screw. Just put in the screw and tighten it. As you keep tightening, because it is a lag screw, as you keep tightening it, it will bring the fragments together and jam them together and give you a good compression. And of course, you need to put 2 or 3 lag screws to assure stability. So this is for long spiral fractures. So this is an example to show their multiple lag screw fixation for a long. The number of screws that you put in is going to depend upon the length of the spiral fracture. The third is open reduction with dorsal plating. It works best for transverse fractures, and we need to remember, I told you this is very subcutaneous. When you do a plate and screw fixation, the big disadvantage is that we need to strip the bone off the periosteum. If this is done, the blood supply is lost. There is not enough soft tissues around the bone to bring back some amount of blood supply, because here there is hardly a tendon on top of it. So it is important to try to bring back the periosteum to cover the plate to prevent the tendon irritation and to provide for good healing of the fracture. The next disadvantage of using a plate and screw is that because the skin is quite thin, you may be able to feel the plate over the skin, which is not very attractive. So here the principle of plate and screw, the basic principles are done, and the fixation of the plate is done in such a way that you are able to get a good compression, and it is indicated for transverse fractures of the metacarpal shaft. We have already seen the long oblique fractures, we are going to do lag screw fixation, and for transverse fractures, we are going to do a compression plating. Now, this is a shaft fracture which the patient has presented about 2 weeks after. You can see the deformity here, the angulation, you can see it, the swelling on the bone, and this is the fixation that has been done. Then lastly, open reduction with K wires and stainless steel wires. Now, it follows the same principle of the tension band wiring. Now, this is the tension. You can put in cross K wires for a transverse fracture, and you can just thread the stainless steel wire over it like a tension band wire loop. Or you can put it through the bone, interosseous wire, in two angles, one transversely and one vertical, horizontally. So this will also ensure good fixation. Now, this is a patient with a fracture of the third metacarpal, a single fracture. Now, what is the indication for fixation in this patient? There was an angulation for this patient and a shortening. The loss of the knuckle is enough, prominence is enough to indicate for an open reduction. Now, the open reduction has been done, and the fixation, it's a single K wire has been done. You can still make out there is an angulation over here, a lateral angulation over here. A single K wire is not adequate fixation. If you're going to do a single K wire fixation, it must be added with an interosseous stainless steel wire or an immobilization with a POP, as K wire fixation, you know, is only coaptive. It's only going to coapt the two bone ends together and does nothing for stability of the fracture. Now, when there are multiple fractures like this, you can make out the wound on the dorsum of the hand and an open wound on the flexor aspect. I told you it is easier to fix the metacarpals through the extensor side, and the X-ray shows a fracture of all the 4 metacarpals. When you have a fracture of all the 4 metacarpals, opening, that is, the incisions will consist of only 2 incisions, one between the second and third metacarpal and one between the fourth and fifth metacarpal, through which all the metacarpals can be fixed. So here the fixation has been done, and this is the end result. Remember, even if you do a fixation, we need to remember that the POP must be applied. If it is a single K wire fixation for a metacarpal fracture, we need to immobilize. That is, you are giving external support to that K wire, because a K wire will not give stability, axial instability will be present. So this is the end result of the healing in that patient. So when we summarize the surgical management of the shaft fracture, shortening up to 1 centimeter is often reasonably well tolerated, but cosmetically it is not. So do not accept that. Shortening must not be present. Patients will always complain of the loss of the knuckle prominence. Second, isolated transverse or short oblique fractures, you can do percutaneous pinning, or you can do a fixation, or you can do the different types of percutaneous pinning. comminuted and multiple transverse or short oblique fractures may be optionally treated with plate and screw fixation. Either 2.0 or 2.0 or 2.4 or 2.7 mm plating system can be used, but a minimum of 4 cortices on either side of the fracture. That is, when you use a plate and screw, you must have minimum of 2 screws proximally and 2 screws distally. If it is not possible, you need to change your method of management. And spiral fractures greater than 2 cortical diameter length. I told you, if it is more than 2 times the cortical diameter, it's called a long spiral fracture, and it may be treated with interfragmentary lag screw fixation alone. So now we will see the metacarpal base fractures. These are quite common. These are usually avulsion fractures. The problem with these intra-articular fractures, these are usually intra-articular fractures, and they usually, if it is the second, fifth, or the third metacarpal, you have got an insertion of an important muscle, the extensor carpi radialis longus or brevis or the extensor carpi ulnaris. So these need fixation, especially with a screw. Now we shall see some metacarpal fractures, clinical studies to understand more about these fractures. Now look at this. This patient has an injury on the dorsum and on the volar aspect, and a fracture of the 4 metacarpals with dislocation of the carpometacarpal joints. Now this is a complication. So this can be fixed. Now I want you to concentrate on the little finger. Just look at the little finger fracture. The fixation looks okay now, but I can make out some gap over there. There is some rarefaction there, that is, there is a lesser amount of bone tissue there. Now this is the result. The skin wounds have healed well. There has been some amount of secondary healing here, but look at the movement at the little finger. You can make out that the movement is much less. Now, so you take an X-ray. This was the original X-ray of the injury, and this was of the fixation. And now how you look at it is, you find that there has been a collapse of the fracture of the 5th metacarpal because the fixation has not been adequate here. Remember, please remember, the K-wire is not adequate fixation. Even if you put a K-wire, the metacarpal will tend to collapse. If there is a loss of tissue, if there is a comminution of the bone at one particular segment, the metacarpal will tend to collapse. Any metacarpal fracture, if there is a loss of bone or is the comminuted fracture, it will tend to collapse. This collapse must be prevented. I told you, shortening will not be accepted. So you need to prevent this collapse. So what we should have done for this patient is, we should have, you can see that gap over there. What we should have done is, while doing the fixation, we should have passed 2 wires like this. I told you transverse K wires can be done. So when you do this, this length will be maintained because this will not collapse. This will be maintained by the fixation to the next metacarpal. So this can be done. So this was not done. You can see the result. There is a compromise in the result. So now let us summarize in a single slide what is the management of metacarpal fractures. Of the head, intra-articular fractures, screws, subcapital fractures, you can put in K-wires. So head, intra-articular fractures, screw fixation is ideal. We are talking about the operative management. The neck fractures, you can do either a closed reduction percutaneous pinning or tension band wiring. These are the 2 main operative treatments. Shaft fractures, you can, if it is a transverse fracture, you can treat it conservatively if there is no angulation, if there is an acceptable angulation, or you can put in K-wires or plate and screws. If it is an oblique fracture, if it is a short oblique fracture, lag screw with compression plate. If it is a long oblique fractures, just lag screws are enough. If it is a comminuted fracture, I did not talk about this. When there is a comminuted fracture, I remember last time when I told you about the plates, there is something known as a bridge plating. That is, it is a load bearing plate. The entire plate bears the load of the hand, of that finger. Here it is a much thicker. I told you, you can use 2.7 mm plates. Those are usually used as a bridge plate because there it allows the healing to occur without allowing any load to be placed on that. If load is placed on that comminuted fracture, healing will not be good. So a bridge plating can be done. And of course, lastly, the base fractures where a screw fixation is ideal. So now we have finished the management of the metacarpal fractures. We need to remember the indications for open reduction mainly. Now proximal phalangeal fractures, we can divide it into distal fractures, shaft fractures and proximal fractures. Distal fractures can be articular. Usually distal fractures are articular. We can have an oblique fracture, unicondylar or bicondylar. And the management of the fractures, again, there is a big important role of non-operative management. Why is non-operative management such an important role in hand fractures? That is because the number of forces that are acting on the hand bones is not as much as the other bones of the body. Secondly, when you go in for fixation, you've got you can end up with a lot of complications. As I told you, what is required in the bones of the hand is not the skill of a carpenter, but the loving care of a gardener, because it is the soft tissues also that must heal along with the bones. So non-operative, only immobilization in a POP. We have got another method of treatment called as a long aluminum splint traction. We used to call it LAST. This is, it would come under conservative management, but you need to put in a stitch or two. The next is external fixation, and lastly open reduction, internal fixation, like in all fractures. Now this is a fracture. I'll show you, sorry. Now this is the fracture. Now this, you can make out the deformity here and a swelling. He is not able to completely extend the finger, and these are this shows the fracture. You can make out a fracture. Now this fracture, if you look at this fracture, you can make out there is a lot of serration. Now that's another important thing to see in hand fracture, in the hand bones fracture. Even if it's a transverse fracture, sometimes you have a lot of serrations. The fracture doesn't break like this sometimes. It breaks like this. Now the advantage when it breaks like that is you have got a lot of bone-to-bone contact when you reduce the fracture. So this will help a lot, help in the healing and stronger union. So there, in those situations where you have a lot of serrations, it is ideal to go in for, you are able to get a good reduction, and at the same time immobilization will help you heal. Now this patient, if you note, this is the end result. All we did was a POP maintaining the 90-degree flexion at the metacarpophalangeal joint, and you can see the result of movement, result of the immobilization. Then, so if conservative management is so ideal, what are the indications for open reduction? Transverse fractures with no serrations. I told you if there are good serrations, you can go in for immobilization. With no serrations, neck fractures and unstable fractures on reduction. Even if you reduce, they're very unstable. Those fractures and neck fractures are never amenable to. We'll see, I'll show you an example of a neck fracture. These fractures are never, you can never reduce them manually. Close reduction. Now the head, when there is a fracture of the head, it can be a transverse, oblique or a multifragmentary fracture. K-wires or mini compression plate can be used. But remember, again, extensive stripping of the periosteum will lead to less amount of healing. So this is a neck fracture. And now in this patient, you can make out that there is a skin loss on the index finger volar aspect, our skin over here, and there are small lacerations on the dorsal aspect of the index and mid. There is an undisplaced transverse fracture on the index finger and a neck fracture. Now this sort of appearance is typically because the fracture has flexed like this. What was like this has become like this. And what we are seeing is the end-on view of the bone. So if you see an appearance like this, a typical neck fracture, and it is virtually impossible to reduce this fracture, and operative management is indicated. So for now this patient, we had a dilemma whether we need to open this finger on the mid finger to fix this fracture. This of course can be managed conservatively, but if you open this, we need to give a flap cover for the index finger also. So that we decided to do a cross finger flap from the middle finger. So the problem, as I said, the skin loss, the undisplaced fracture on the PPX of the index, and the displaced fracture on the neck of the PPX of the mid finger. So we took a cross finger flap from the middle finger and used, after this it was elevated, we used it for fixation of the, you can make out a K wire there, and we put a skin graft to cover it. And this was the result of the fixation. So what was the end result? The flap has settled well, and the donor site has also healed well, and the fracture has also healed well. But how was the movement that was achieved? You need to get a good movement after this. We do not know whether there's going to be a scarring that is going to inhibit the movement of extension or flexion of the PIP joint and the metacarpophalangeal joint. Now, this was the movement that we achieved at the end of 1.5 months. So now this is important to remember that fixation of the neck fracture of the PPX is very important. Now we come to the shaft fracture. Now the shaft fractures, I told you, if it is a transverse fracture without any serrations, we need to fix it. This fixation can be done with K wires, SS wires, compression plate, or if it is a comminuted fracture, bridge plate. Now we have understood that if you want to get compression, you need to use a compression plate. If you want to get, if you want to overcome the area of comminution, you use a bridge plate, or you can use K wires and SS wires too. But remember, this again is very subcutaneous. The bones are subcutaneous, and you can have problems. And using stainless steel wires have got an additional disadvantage in that they are left inside in situ. And even though we remove the K wires, the SS wires are remain there, and this may cause a problem of impinging on the skin underneath. Now, if it is a long oblique fracture, screw fixation length screws can be used. Like how we said, for the metacarpal shaft, you can use lag screws for fixation. And just as we saw about how the metacarpal shaft fractures are fixed, the proximal phalangeal fractures are also fixed. Next is transverse fracture, interosseous wiring. Now, usually there are two types of incision that are described. One is the dorsal S-shaped incision, which is made on the dorsum of the proximal phalangeal region. But there is a problem in this. When you make an incision like this and you raise the flaps and fix it, this suture line overlies the entire length over the fracture, over the extensor tendon, which may get adherent and restrict the movement. So usually the cross finger flap, that is like a cross finger flap, you raise it like a flap, it does not cause adhesion to the extensor tendon. At the same time, it affords a very good exposure to the fracture. So this can be done. So now this is an example of a PPX shaft fracture fixed with a K wire. A straight single K wire again is not rigid fixation. It is not even stable fixation. This is only coaptive fixation. We need to give a POP to give extra support to the fracture, and this is the result that can be obtained. Now look at this picture. You can make out that there is a deficit over here. It's like this. There is a deficit. Now why does this deficit occur? It usually you have to look for it. There are two reasons for why this deficit occurs. One, when you are immobilizing it in a POP, you can make it out even on this picture. You can make out the little bit of flexion at the PIP joint. When the IP joint is not kept exactly straight and kept in a minimum amount of flexion, it becomes stiff because the volar plate gets adherent to the bone. So that causes a little amount of flexion of the PIP joint, which is quite a common occurrence if the POP has not been maintained correctly. Second, then you have, now look at this fracture. If you look at this fracture, you can make out the callus over here and over here. Now this callus gets stuck to the extensor and prevents the extensor from completely extending. Now that is that is one of the disadvantages of K wire, because you're going to have a callus. Remember, when you put in a plate and screw, it is primary healing. You will not have a callus. You will have good mobilization. But there is a disadvantage of plate and screw because it is going to be very subcutaneous, and you're having an implant which is inside, which is retained inside. Now, conservative management can also be done in motivated patients. Now look at this X-ray, look at this injury. There is a laceration over here. You can make out the deformity, and there is a pretty bad fracture, comminuted fracture. Ideally, this should go in for a bridge plating or an external fixator application. As you know, the treatment for comminuted fracture of the hand bones is either bridge plating or an external fixator, especially if there is an external wound. What we did not have the external fixator or a bridge plate. So what we did was we did a POP, immobilization. I told you, whenever you have an option to do an internal fixation, yes, but if it is not available, always go on the side of non-operative management, and you can do, we have done an immobilization of the fracture. Now, at the end of 1 month, this was how it was. After we removed the POP, this was the movement. After 2 months, it improved with physiotherapy. And after 3 months, you can make out the wounds have healed well and the movement is almost back to normal. There is about 80 to 90 degrees of flexion at the PIP joint. And this is the X-ray. It is very important that the patient, you follow up the patient, even if it is a bad comminuted fracture like this. Why I am showing you this picture is not to say that comminuted fractures do a conservative management. But if you do not have the ideal management of operative fixation, conservative management is a safer option. It can be done, but remember, the amount of effort that you as a surgeon has to put in for following up the patient is more in such patients. Now, coming to the basal fractures of the proximal phalanx, you can use mini condylar plate or T-plate. It is very difficult to approach the basal fractures because it comes into the web. It is very difficult to approach. You may have to split the extensor tendon, the extensor sagittal hood to approach these fractures, and the fractures, the healing is not, it's going to have a lot of scarring with the extensor tendon which is just above it. So it is ideal to put in either mini condylar plate, T-plates or lag screws. And similarly, conservative management of base fractures, avulsion fractures can be done, or lag screw fixation can be done. But please remember, it is very difficult to approach this area. So we must remember that fixation must be comfortably done. Only then you can get good results. Now, there is another method of management for head fractures or basal fractures of the middle phalanx. Head fractures of the proximal phalanx or basal fractures of the middle phalanx. It is called, I told you, it is one of the conservative methods. It is called long aluminium splint traction. Now here, this is the injury. You can make out the deformity. Patient not able to flex it completely. You can make out the deformity here. And this is the base of the middle phalanx, this is called a pylon fracture. Now, this is called the long aluminium splint. A POP is applied here only for the wrist, and an aluminium splint is applied over here, and a traction is applied from the tip of the finger. Now, the basis of long aluminium splint traction is that when you have a fracture like this, what you need to do is you need to pull it out. Our aim is to prevent this from jamming the joint and preventing joint movement. So you need to keep the joint open. So you need to apply force or traction to keep the joint open. But if you apply traction like this, all the joints will open up. You need to concentrate on the PIP joint. So what you need to do is you need to flex the finger and give counter traction on the metacarpal bone, so that when you flex the finger and then give traction, you are able to open out the PIP joint and maintain the space, PIP joint space. So when you flex the finger, the traction is applied here. This is the counter traction applied by the POP slab that you have given. So this will result. This patient, you can see the amount of healing that has occurred. Even though the space is not as good as in the normal space, you can clearly make out the joint space available. And what is the movement? This is the movement that we get. So it is when you want to manage a proximal phalangeal fracture, a conservative management, or a middle phalangeal fracture, base fracture, a conservative management is ideal. So lastly, we come to what is known as a pylon fracture, that is of the head of the proximal phalanx or the base of the middle phalanx. Now these fractures are comminuted intra-articular fractures where both the dorsal and volar cortical margins are involved of the middle phalanx. Now it is difficult to fix once it is open. Now it is all lying there because the soft tissues are holding it together, small fragments. When you open it, they just fall out like that. So there are two methods to fix it. One, they are called dynamic external fixation. It can be done by one of two methods. The Hines and Giddens popularized a dynamic external fixator without the use of rubber band traction, and pins and rubber traction system described by Suzuki. So this is the dynamic external fixator splint. You put in 2 K wires. This is the base of the middle phalanx fracture, and this is pinned like this over it so that the patient can move the PIP joint while maintaining the traction on the PIP joint. This is a Suzuki frame, the same thing, which is extended with a rubber band so that the same movement can be applied. This, we shall also see the epiphyseal fractures. You can make out the epiphyseal fracture. I told you, when in doubt whether we can put a K, we try to avoid K wires through epiphyseal plates. If it is necessary, yes. But in these patients, look, I can make out there is a wound over here, and you can make out the deformity of the little finger, and you can see the fracture here. But this can be managed with conservative management with just immobilization. The management of hand fractures conservatively should be thought of in any patient. Complications, you can have complications. Now, I told you, when you try to do a fixation and it is misguided, you can have more complications than good results. Now this is the patient, he's got the scarring over here, you can see the deformity, there is absolutely no extension, there is a contracture, and look at the fixation that has been done. You can make out it is neither, it's not at all in the bone, and it is preventing the movement. The same, if it had just a POP had been applied, you would have got much better results. Or look at this patient, look at this, it has healed in this position. It has no traction has been given, nothing has been done. It has healed in this position, and you can make out the deformity. There is no flexion, there is no active, full range of extension is not there, and there is no flexion. There is a fixed flexion deformity at the PPX. Now we come to the other middle phalangeal fractures like the head or the shaft. The principles of management of middle phalangeal fractures are the same as for proximal phalangeal fractures. Here, proximally, I told you the pylon fractures, the multifragmented fractures we have seen already. The avulsion fractures we shall be seeing now, and the dislocations we shall not be seeing in this lecture. Now this is in all the fractures of the proximal phalanx or the metacarpal or the middle phalanx, please remember viability. This I had spoken of in my first lecture on hand. Any injury to the hand, even a small punctured wound, please confirm the viability before you go ahead and plan your management. If the viability can be lost even by very small factors. So in this sort of injury especially, we must confirm the viability, or if the viability is not there, we must ensure the viability is re-established before managing the fracture. So this is a fracture like this. You can make out a base fracture, and transverse K-wire has been used. So remember the basics: conservative management, K-wires, screws, plate and screws. That's all. So now this is a neck and shaft fracture of the middle phalanx. Similarly, in the middle phalanx, a shaft fracture can be fixed with a straight K-wire passed through the interphalangeal joint, distal interphalangeal joint, and this is the movement that results. Now, when there are avulsion fractures like this, it makes it a little more complicated because these fractures are very difficult to address, and we know that there is an attachment of the collateral ligament or the volar plate or some tendon. If it is on the dorsum, it is the central slip. Now, how do we address these fractures? There is a very good classification system for avulsion fractures of the base of the middle phalanx. We have got two main classifications called the Eaton classification and the Kiefaber-Stern classification. Now, the Eaton classification is mainly soft tissue, or type 3 is fracture dislocation less than 40% of the PIP joint is involved, or type 3B, where the fracture dislocation more than 40%. So depending on whether this fracture segment is less than 40% or more than 40%, the treatment is planned. Now look at this. Here it is almost 50%. So this would come under type 3B of Eaton classification of avulsion fractures of the middle phalanx. According to the Kiefer-Stern classification, he has classified it under stable, tenuous, and unstable. So this is classified according similarly to the Eaton classification, according to the amount of bone joint that is involved. So ultimately what we are bothered about is maintaining the joint line and maintaining the movement at the PIP joint. So for Eaton classification type 1 to 3A and Kiefer classification of stable or tenuous, splinting with extension block immobilization. So conservative management. Whereas for type 3B or Kiefer unstable, that is the most severe type of the Eaton or the Kiefer classification, we need to go for fixation. Fixation can be done either with a volar plate arthroplasty or the Suzuki frame or K-wire stabilization or screw fixation. So when you have an volar plate avulsion fracture, we need to decide what is the type of fracture under the classification of Eaton or Kiefer and then decide on the management. The first three types of Eaton will be managed conservatively. You need to fix it in this. You need to immobilize in dorsal block spinning. That is, you do not allow it to go in for complete extension. You need to keep it in flexion. And then if for reduction of the fracture you need more than 30 degrees of flexion, it goes under the severe type. Similarly, this is on the volar aspect. Similarly, you can have an avulsion fracture on the dorsal aspect. On the dorsal aspect, the treatment is more simple. Imatami has classified into three types. But this classification is more on the type, the mechanism in which the fracture occurred. Type 1 is the avulsion type, type 2 is the split type, and type 3 is the split depression type. But whatever be the type, fixation, screw fixation or bone anchor suture if the bone segment is very small, or fixation if the bone segment is large, must be done to get back to correct this boutonniere deformity, because what results in this is a boutonniere deformity. So this is the type of fixation that can be done for this fracture, central slip avulsion. You can also apply external fixator. Remember, whenever there is a comminuted fracture or avulsion fractures, external fixators can also be used. Terminal phalangeal fractures. We come to the last type of fracture, the terminal phalangeal fractures. Tuft fractures. You know the three parts of the terminal phalanx: the tuft, the shaft, and the base. The tuft fractures usually tuft and shaft fractures usually associated with nail plate injury. There is an avulsion, partial avulsion of the nail plate, which should be fixed. There is no need for internal fixation of terminal phalangeal fractures except in 1 or 2 rare conditions. That is because the blood supply to the terminal phalanx is the least. It is the tip of the finger. The blood supply is the least. There is not adequate soft tissue. So the fixation is best. Most conservative management is ideal. However, the most important step for management of these fractures is debridement. A good wash. If a good wash is not given, even if you're doing a skin suturing with a fracture of the terminal phalanx, you're doing a nail repositioning, please remember the debridement or the washing of the wound must be done thoroughly, because even a little contamination there will lead to infection, and because the blood supply of the terminal phalanx is so low, you can have a absorption of the entire bone before the wound heals. Shaft fractures also, nail repositioning is enough to bring them. There are no forces acting on the terminal phalanx distal to the shaft. Whereas on the base, types of fractures can occur. One is the fracture that occurs distal to the insertion of the extensor apparatus, the terminal tendon of the extensor. So there what happens, the proximal segment, both the extensor and flexor are attached, whereas the distal segment, only the flexor is attached, because by nature the flexor attachment is a little longer than little more distal than the extensor attachment. So the finger, the tip of the finger goes in like that. So it is something looks like a mallet deformity. It is not a mallet deformity, and patient will be able to extend the DIP joint, but the tip of the finger will be pointing downwards. This is called a Seymour fracture, or a pseudo mallet deformity, or a pseudo mallet fracture. This fracture may sometimes need K-wire fixation, straight K-wire to maintain the position. Otherwise, the flexor will tend to flex the distal fragment. Avulsion fractures are common. You can have an extensor avulsion or a flexor avulsion. This is the anatomy of the terminal phalanx to show the different parts, and the shaft fractures and the tuft fractures, which are usually managed conservatively with a good debridement and conservative management. Avulsion fractures, as I said, can be on the extensor side or on the flexor side, and as you know, the avulsion fractures on the extensor side can be classified by the Doyle classification of mallet injuries. And here, type 4B, you can make out it involves 20 to 50% of the joint surface, and 4C involves more than 50% of the joint surface. The basic principle is fixation of these fractures is very important to get back full function. So screw fixation or bone anchor, if it is a type 1, that is a small avulsion fracture, can be done, or there is what is known as extension block pinning that can also be done to ensure good fracture healing. This is the avulsion fracture which needs to be pinned, or an extension block pinning can be done, or otherwise known as the Ishiguro technique. For the volar side avulsion fracture, you can do what is known as the Leddy-Packer classification, and as you know, the type 3 and 4. The type 2, where the FDP retracts to level of the PAP joint because there is a small avulsion fracture, and type 3, the large avulsion fracture, it does not retract at all, and both have to be fixed. So this is to show the Leddy-Packer fracture. Now, before we wind up, there is a guide for K-wire fixation. What is the size of the K-wire to be used for the different bones? For the terminal phalanx, 1.2 mm. For the middle phalanx, also the same caliber. For the proximal phalanx, 1.5 mm. This is not binding for all. This is for an average adult-sized finger. And for the metacarpals, 1.8 to 2 mm K-wires can be used. For lag screw fixations, again, TPX or MPX for avulsion fractures, when you're using it, you can use 1.3 to 1.5 mm for the terminal phalanx and middle phalanx. For the proximal phalanx, we can use 1.5 to 2 mm, and similarly for the metacarpals, 1.5 to 2 mm screws. Similarly, for plate and screw fixation, of course, terminal phalanx we don't have. For middle phalanx, you can use 1.3 to 1.5, the proximal phalanx 1.5 to 2 mm, and for the metacarpals 2 mm plate and screw, remember you can use up to 2.4 and 2.7 mm plate and screw if you're going to do a bridge plating. So that brings us to the end of the management of fracture management of the individual bones of the hand. When you look at the entire lecture, the important things are, I stressed on certain things. One is the importance of conservative management of fractures of the hand. Why? Because you can get good results, and movement is most important. It is not like the other bones of the body where the stability is important. Here it is movement. And when you are talking about movement, you do not want any stiffness to occur. The bones are all subcutaneous. There is not adequate soft tissue padding. So the healing of the bones may be compromised if you go in for an internal fixation. Still, there are indications for internal fixation. You want to have early movement, you must do internal fixation to get back good movements. I hope you are able to understand the basics, and you're able to understand how the decision is made when you have a fracture of the hand, whether it's a metacarpal fracture, proximal phalangeal fracture, or middle phalangeal fracture, or even terminal phalangeal fracture, what is to be done. So now, before we wind up, the quiz question: where is the Mulliken-Glowacki classification, and what is the classification based on? Yes? Any answers?
Sir, for vascular malformations, sir.
Yes, good. It is used for vascular malformation. It is used for vascular malformation. What is this classification based on?
Sir, I don't
So
know.
biological classification.
Good. It's a biological classification. What does that mean? Biological. That is the exact term. Biological. What is it? What does it mean actually?
So
The biological classification means it is based on the endothelial cell characteristics, physical findings, and natural history that differentiates vascular lesions with endothelial cell proliferation. Now, what Mulliken and Glavacki, the main thing they said was there are two things. One is known as a hemangioma, and the other is or vascular anomaly. The other is known as a vascular malformation. So if there is endothelial cell proliferation, that is biologically it keeps proliferating, it is known as a vascular anomaly, of which hemangioma is the most common. And lesions with structural anomalies, they are called vascular malformations. So that is the meaning of the biological classification that was put forward by Mulliken and Glavacki in the year 1982. Remember that because it's a very important. What is the main classification we use nowadays for vascular anomalies? The
ISCA.
Yes, the International Society for Vascular Surgical Anomalies. Okay. So now, any questions?
Sir, I have a question, sir.
Yes.
Sir, until definitive fracture fixation, sir, what is the POP we are supposed to give? So is it position of immobilization, position of function, and is it the same for all the fractures of the hand?
Yeah. Now, we need to remember this. Whenever the first thing I told you is viability. If there is a problem of viability, always give a POP like this. That is, do not put the wrist into extension when there is a viability problem because it leads to some tension on the vascularity. So we don't want that. So you give a resting POP in a dorsal POP. Whenever you put a dorsal POP, we never put the wrist into extension. I told you it causes crinkling up of the POP on the dorsal aspect of the wrist. That may cause compression. So whenever you put a dorsal POP, the wrist must be in neutral position. When there are only fractures and there is no compromise of the blood supply and you're waiting for the definitive management, this is the POP to be applied. This is the lumbrical position. You know the lumbrical position? Here, you keep the wrist in minimum extension, MCP joints flexed, IP joints extended. This is the position. Now, there is another position known as the position of ease. This is the position of ease. This position of ease should be avoided. This is when you leave your hand at ease, this is how it goes. Patients who have got an injury or burns will hold it like this. This is the position of ease which should be avoided. Next is glass folding position or functional position. This is the functional position. Here, the difference between the lumbrical position or the intrinsic plus position and the functional position is that here, even here in the functional position, there is an extension of the wrist. But the difference comes in the metacarpophalangeal joint and the interphalangeal joints. The metacarpophalangeal joints are not so acutely flexed in the functional position and the IP joints are flexed in the functional position. It's otherwise known as a glass folding position. So this is the functional position. So if there are very bad fractures, they are immobilized this so that at least they'll be able to do some amount of function. Whereas this is a lumbrical position which must be maintained when you have a fracture and you're planning to do a definitive management. This is the position you want to achieve, not the functional position.
Sir, regarding opening metacarpal fracture, like you showed a couple of pics, there were multiple fractures and there were K wires inserted. So, like, didn't get that whether you opened and inserted K wire or it was percutaneous pinning considered as ORIF.
Yeah. Now there are two types of KY. Pinning can be done in two ways. You can do it closed. That's what I said. It is closed reduction. Percutaneous pinning can be done. Okay. If it is a simple fracture and you have got the facilities, remember for doing this you need C-arm. If the C-arm is available, it is a simple fracture and it is an unstable fracture and there is no indication for an open reduction. You can do a closed reduction and percutaneous pinning. Here what happens, under C-arm, the wire is passed through the collateral recess. Now this, on the lateral aspect of the metacarpal joint, you have what is known as the, you can make out a depression there. Through that, you put the wire inside and under C-arm magnification control, you drive that past the transverse fracture. Usually it is ideal for transverse fractures or even sometimes neck fractures, but you put in 2 or 3 wires. Sometimes they even have malleable wires. So these wires are put in either antigrade, retrograde or antigrade from here. That is closed reduction. If you do not have a C-arm and you find that you have to fix it, then you have to go in for an open reduction. So given the options, you have a C-arm, it is good to go in for a closed reduction percutaneous pinning.
Okay,
Does
sir,
that
thank
answer
you.
your question, Kunal?
Yes, sir. Thank you, sir.
Yes. Any other questions?
Excuse me, sir.
Yes.
Sir, if we get a patient with crush injury, say like a press machine injury, and there are longitudinal fractures of the phalanges, either the middle phalanx or the proximal phalanx, and the fracture segments are shattered, and they are longitudinally through to the head to base. So in such cases, if we are not able to either fix with a plate or either with even a SS wiring, cross SS wiring, then how should we manage, sir, such patients?
I understand that you're talking about longitudinal split fractures.
Yes, sir.
Okay, longitudinal split fractures. If there is only an open, it's an open fracture, isn't it?
Yes, sir.
It's a skin injury. Okay. So if it's an open fracture, longitudinal split fractures, what you can do is you have what is known as a circlage wiring. I told you you can use stainless steel wire through the bone and you can fix it. Like you can use it for tension band wiring. In these sort of split fractures like this, you need to bring it together and hold it together like that. For that, you can use what is known as a circlage wiring. You pass the stainless steel wire, 24 gauge wire around the fracture, then you tighten it. That is circlage wiring that can be used for longitudinal fractures. Supposing the longitudinal fracture doesn't extend throughout the complete bone, you can do a lag screw. But your question itself, you said it's not available or something, isn't it? The lag screws
Yes,
are not available.
Yes,
In
sir.
that situation, a circlage wiring will help. We used to do circlage wiring. We did not want to put in an SS wire there. We used to put in a proline stitch, a thick caliber, one proline. We used to put a stitch there, but that is not very ideal. Some people say you can put in a vehicle stitch. It will not work. So you can use circlage wiring using stainless steel 24 gauge wire. But remember, it is going to be an implant which is kept inside. So it is prone for getting infected and causing problems later on.
Okay, sir. Thank you, sir.
Thank you.
Sir, one doubt, sir.
Sir, will you please explain about pseudo mallet finger again, sir?
Yeah, I'm sorry, I had forgotten to make a diagram, See, this is the terminal phalanx, right? Now here the extensor is attached, here the flexor is attached. You understand that? Okay. Now, you find that the extensor and flexor are not exactly attached like this. The flexor actually goes for a little more on the volar aspect. Okay. So if you have a fracture at this point, the extensor and flexor are attached to the proximal segment, and to the distal segment, only the flexor is attached because the flexor has got a little more insertion. So what happens, this distal segment is pulled only by the flexor and it flexes like that. So it looks on the outside, there is an injury over here and there is a deformity of the finger. So when you look at it, immediately you think it's a mallet deformity. But if you ask him to extend it, that little segment over there, he will be able to extend it. And if you take an X-ray, you can make out that the fracture is not an avulsion fracture of the terminal phalanx, but it is a fracture of the shaft of the terminal phalanx distal to the insertion of the extensor and flexor. So that means this fracture there is no mallet deformity. Only thing, the finger is not there. So when you bring it back, what happens? The flexor force will continue to act. So it is ideal to fix this with a very thin K-wire passed retrogradely to fix this fracture. So this is called a pseudo mallet deformity. It looks like a mallet deformity, but the extensor, what is a mallet deformity? The extensor is disconnected. That is what is called mallet. Here the extensor is not disconnected. The extensor is still connected to the base of the terminal phalanx. It is only the fracture of the terminal phalanx that has occurred distal to the insertion of the extensor tendon, just distal. So what happens? It looks like a mallet. It is not a mallet. Does that answer your question?
Thank you, sir.
Yeah.
Sir, I have a doubt.
Yeah, somebody.
In a case of multiple fractures in the hand, when do we decide to go in for a hand frame or a just fixator?
There you have me. I do not have any experience with just fixator. I have actually, I have done the crime of not talking about the just fixator, which is an excellent method of fixation in people who are expert at it. I am not an expert. I do not have any experience. I think you should learn that from people who are are expert in that. It is a good method of management. I have just touched upon external fixation in some of the points that I spoke about. But just, that is the external fixation system is quite good, but I do not have any experience. I'm sorry.
Thank you, sir.
Sir, your views about bouquet technique for fifth metacarpal neck fracture?
What technique?
The bouquet technique, bouquet, intramedullary nailing. That. Sir, for fifth.
Beg your pardon?
Sir, for fifth metacarpal neck fractures, there was an article about this bouquet technique. So they are putting pre-bent K wires, something like that.
Yeah, that is exactly what I was telling about now, the close reduction and the percutaneous spinning. That is what it is. It is actually very good. When you have a simple fracture, you try all the methods possible to avoid opening it. That is what I was trying to say from the beginning. If there is some method like this. Now, this is a pre-bent wires. Pre-bent wires they're already bent. When you put it in, when you drive them in straight, but when they get inside, they will immediately bend. They'll go into their position. So they hold it up. For instance, if you got a fracture like this, you put in a bent wire like this. Okay. So when there's a fracture like this, as soon as it goes in, it will hold it up like that. It will go into that same position. It holds it in that position. So what you wanted to do was convert that tension forces into compression forces. That is done from inside, from the intramedullary portion by the pre-bent wires. So this is another technique of the close reduction and percutaneous spinning that is done with pre-bent wires. If that is available, excellent. There are so many techniques. These are all the basic principles. If you're able to understand, you'll be able to understand all those techniques also.
What is your view about double-headed screw, intramedullary?
Intramedullary?
That is Herbert screw or something like that, in soft fracture especially.
Yes. Herbert screw, I do not know, sir. I have not used it except in a scaphoid fracture. And only headless screw. You're talking about headless screws. Headless screws we usually don't use on the metacarpal bones. Only lag screws are used. Herbert screws, I do not have any experience in using on metacarpal fractures or on the fractures of the hand.
Intramedullary, what I mean to say, through the head.
Yeah, correct. The lag screws, yes, I have used, but not the headless screws.
Excuse me, sir.
Yes.
Good evening. Sir, in case of an open shaft of P1 fracture, which is a multi-fragmented fracture, and there are many loose fragments, are we to retain those loose fragments or are we to remove them? Because when we do a fixation.
Yeah. Now, when you do any fracture of the hand and you see a lot of loose fragments, okay, it is an open fracture, you said, isn't it? So if it is a simple fracture, just conservatively mold because it has not yet become open. If it is simple fracture, conservative management or external fixator would be ideal. But if it is already an open fracture, it is already open to the external environment. Here, we have to decide which fragment to retain, which fragment to lose, or can we retain all the fragments? Because if you remove some fragment, you're going to have a bone loss. So, the main thing that decides on whether you're going to retain it depends on what is the soft tissue attachment. If it has got enough soft tissue attachment, if there are fibers still holding on, you can always retain it. But if there is not, if it is loose, it must be removed, obviously. But even that soft tissue attachment which you're retaining may not be good enough. You do not know how vascularized, how that soft tissue, whether that soft tissue is vascularized, we do not know. So there, it is only clinical judgment. It's very difficult to decide on those that are free, you remove. Those that are attached, well, yes. It is only those small fragments that are doubtful this way, that way, you need to take a chance. If you retain it and it gets infected, it will form a sinus, it will come out. However, if the healing is good, it may get incorporated into the fracture healing also.
So in that case, how are we supposed to fix the fracture? It's a shaft of P1 fracture, multi-fragmented with loose fragments. And in my institution, we mostly do a K-wire fixation. In that case, how are we supposed to go ahead with the fixation? Especially if it is a longitudinal fracture with multiple loose fragments. What are we supposed to proceed with, sir?
So in that situation, you've got a few options. One is, we'll start again. Conservative management, as you said, K-wire fixation, then you got external fixator, then plate and screws, or screws alone. You cannot put screws. You said it's a proximal phalangeal fracture, isn't it?
Yes, sir. Yes, sir.
Yeah. Proximal phalangeal fracture, when you got multiple fractures, fragments like this, it is very difficult to keep fixing everything with a screw. The problem is, you can put in nice screws and look nice on the X-ray next day. But are those segments vascularized? We do not know. So screw fixation is ruled out. Second, we talked about plate and screw fixation. When you put a plate and screw fixation, you need to have a good purchase proximally and a good purchase distally of the bone. Here, I do not know if in your fracture it is there. If it is not there, it is not possible. You can do a bridge plating if there is a small segment of comminuted fractures of the shaft alone. Then you can do a bridge plating. But if not, if it is more on the base or more on the head region, you cannot do a plate and screw. Then we talked about external fixator. External fixator is ideal. You can put an external fixator, especially if there's an open wound and you need to give a flap or something, you can do an external fixator. So external fixator is one good option. The next is K-wire. The problem with K-wire is, when you put in a K-wire, it will not prevent the collapse. And I told you it is not good fixation. So it will collapse anyway. And your K-wire is not going to add much. It may add to the infection. That's the only problem. So K-wire is also not a very ideal option in such patients. The other option, last option, is conservative management. So conservative management versus external fixator. These are the only two good options available in this, what I can imagine, what you are talking about.
Okay, sir.
K-wire fixation may help to heal the wound. When you put in a K-wire, the amount of movement is reduced. The pain will come down for the patient. But about the healing, I am not too sure. It is a little it's something like a gamble.
Okay, sir. Thank you, sir. Thank you so much.
Sir?
Yes, Joel.
In the apex dorsal deformity that we see in the metacarpal shaft fracture.
Yes.
Is the deformity named after the distal fragment or the proximal fragment, sir?
It is named after the distal fragment. After the distal fragment.
The distal fragment.
So when you have an angulation, I told you the fracture goes like this, isn't it?
Yes.
So this is angulated volarly.
Yes.
Okay. So the angulation is like this. So angulated volarly. And the displacement is dorsally. It's displaced dorsally.
Okay.
Okay.
Okay, sir.
So, any more questions?
Good evening, sir.
Yes, Brahmadat.
Yes. Sir, sir, you mentioned about metacarpal head fractures. So in the case of a metacarpal head fracture, which is isolated, single metacarpal involvement, what would be the external fixator technique? You mentioned external fixation as an option. what would be the technique of external fixation that you would use in such a case?
Yeah. See, the main aim of external fixation is you want to maintain the length. If it is only a fracture of a bone that is not involving the articular surface, you want to maintain the length of the bone. Supposing it is an intra-articular fracture, you want to maintain the space, joint space. You want to maintain the length of the joint, so to say, the length of the joint. So as far as the metacarpophalangeal joint, intra-articular head of the metacarpal is concerned, it is very difficult to put an external fixator like this, that is straight. You need to span the joint, or you have to put it in this position. That is, you keep the metacarpophalangeal joint in flexion. Now remember, when you keep the metacarpal joint extended, now the aim is to keep the joint in maximum space, that is expanded. So here, when you keep the joint flexed, you have more space. When you keep the joint extended, the bone goes very close. So you need to keep the joint flexed. When you keep the joint flexed, you have to apply an external fixator with 2 pins here and 2 pins here. It will be an oblique. It will go in an oblique fashion over the metacarpophalangeal joint. So you cannot keep the joint like this. It's easier to put 2 pins here and put an external fixator. But that will keep the MCP joint in extension, which is not good for the healing of the joint. Your aim is to maintain the joint space. So to maintain the joint, you have to keep it in flexion. So this may need a hinged joint. You have to have a, when you put in 2 pins here and 2 pins here, it's not possible to put a wire across. You need to put 2 pins here and you have a joint over here. It is possible to have a hinged external fixator. We have seen one hinged external fixator. We saw the mobile hinged external fixator. Here you can have an external fixator with flexion at the metacarpophalangeal joint.
Okay, thank you.
Okay, so if there are no more questions.
Rakesh Kumar Sinha, you have any question? Your hand is raised for a long time.
Sir, good evening, sir. Maybe it's a simple question. I wanted to ask, sir, how many layers of POP? Just a basic question, sir.
That's interesting. That's a very good question. I love questions about conservative management because that's the most important. No? Whatever you do, ultimately you need to put a POP. Now, POP, usually we put in 12 to 14 layers, okay, of 4-inch POP, 10 centimeter POP for the hand. I'm talking about for the hand, for a normal adult size hand. And this, when you apply the POP, I remember at one point I said, thin padding, don't put too much of pads. When you put too much of pads, what happens? What you think is 90 degrees is actually only 50 to 60 degrees. Okay? Remember, you put your MP joints into flexion of 90 degrees and see how it comes. Your thumb is projecting above the fingers. This is how it should be if you want to get 90 degree flexion of the metacarpal joint. The more padding you put, the less will be the metacarpal joint flexion. So, thin padding and the POP, and remember, the fold of the POP does not come here. It comes here at the distal crease. If you put the POP folds at this level, it will prevent the MP joint from flexing. Okay? So it's a good question. We use 12 to 14 layers. That is enough. That is ideal. With a good POP, of course.
Thank you, sir. Sir, any like metacarpal gaps more than 1 centimeter are you dealing later, sir?
Yes. We have not talked about bone loss. I have talked only about fractures. When there is bone loss, I told you, more than 1 centimeter shortening will not be accepted. So if there is a bone loss, you need to make good that loss. You need to correct it. So how do you correct it? You need to put a bone graft.
Yes, sir.
Now, when do you put a bone graft? Can I do it today? Today the patient has come to me. There is a gap of about 1 centimeter. Can I do a bone graft? No. Very good. You can do a bone graft, provided you are able to give a skin cover. Supposing there is no problem with the skin, there is only a laceration, but there is a bone loss. That is a little doubtful because with just a single laceration, it's difficult to have a bone loss. So most probably there is a skin loss. Okay. Can I give a flap cover today and also do a bone graft? Yes, you can do it. Now, supposing the skin loss is so much, but the bone loss is also a lot of bone loss is there. I cannot do a bone grafting today. I can do it as a second stage. So the flap becomes an important procedure. In that case, what do I do to the bone? Can I just leave it like that, or should I just give a skin flap? No. If you just give a skin flap, by the time the skin flap gets ready and it is free, your bone has collapsed so much you cannot bring it back. Okay, so you cannot get back the leg. So you should maintain that space. How do you maintain that space? You can do either internal spacer or external spacer. External spacer is external fixator. Okay, you know that. Or internal spacer, you can do what is known as bayonet wiring. That is, the K wire, you pass it proximally, bend the K wire like that. Okay, like that angle, and fix it into the distal. So this will prevent the bone from collapsing. All bone, if there is a loss, it will collapse. That is nature. So to prevent that, you must maintain that space either externally with external fixator or internally with an internal spacer. Right?
Thank you. Thank you so much. Thank you so much.
Okay.
Sir, one more question, sir.
Yes.
Sir, in a base of metacarpal fracture of the base of the metacarpal, when would you consider conservative management?
Yeah, I would consider conservative management when there is not much of displacement. Okay. Now, the fracture, usually I told you, if it is a base of the fourth metacarpal, I would manage conservatively. If it is a base of the second, third, or the fifth metacarpal, I look at the lateral view, true lateral X-ray, to see if there is an avulsion, if there is a displacement. If there is displacement, I would go for fixation, open reduction, internal fixation. If there is no displacement, I would manage conservatively. Sometimes it is possible that the fracture has occurred through the insertion. That is, the insertion is there, but the fracture is through it. So in that situation, there is no need to fix it. Just manage. So management of base of metacarpal fracture will be open reduction only if there is a displacement of the base of the fracture fragment.
Okay, sir. Thank you, sir.
If there are no more questions, thank you, sir. Thank you for a long, wonderful lecture and very patient answering your questions. And somehow, all this plastic surgery Chinese seem to love you so much. I don't know what is the magic, but if you can tell us the secret, at least we'll get some more.
The subject is so interesting. Subject is so interesting, sir.
I think you have turned many, many youngsters into plastic surgery, I'm sure.
Great. Thank you.
Thank you, sir. Thank you, sir. We'll see you again next week. Thank you. Have a nice week.